Hello, I'm Hank Paulson. I'm director of the Michigan Alzheimer's Disease Research Center at the University of Michigan and the Lucile Groff Professor of Neurology. It's my pleasure today to talk to you about the neurology of HIV. Firstly, I want to thank the Alzheimer's Association and the Michigan Department of Health and Human Services, which worked together to provide a grant that allowed us to make these educational programs on HIV disease and cognitive impairment. Now, of course, HIV is known as the cause of AIDS, and I will not be talking today about the myriad of neurologic complications of the entire AIDS complex. The advent of combined antiretroviral therapy 25 years ago has changed HIV disease from something that kills people rapidly to a disease that people live with chronically for the rest of their life. And I will focus today more on those age-related neurologic complications of HIV disease that persons living with HIV disease experience. Let's begin with some definitions that you'll see throughout this talk. One is HAND or HAND, which is HIV-associated neurocognitive disorder. HIV-associated dementia is HAD. Persons living with HIV is PLWH. Asymptomatic neurocognitive impairment is ANI. Mild cognitive impairment, and they're both amnestic and non-amnestic forms of mild cognitive impairment, is MCI. When I say dementia, I'm mostly talking about Alzheimer's disease, but it's important to recognize that dementia represents several dementias, and the term ADRD means Alzheimer's disease and related dementias, such as Lewy body dementia and frontotemporal dementia. And finally, CART is combined antiretroviral therapy. HAND versus dementia. This is a major part of the talk today. These are different disorders, but they have similar phenotypes, and that can be very vexing in trying to distinguish when someone has HAND and they have HIV versus have an underlying or superimposed dementing process. Let me point out that HAND refers to several different components along a spectrum, from asymptomatic neurocognitive impairment through mild neurocognitive disorder to frank dementia caused by HIV. And then when I speak about dementia, and again, this is mostly Alzheimer's, I'm talking about impairment in more than two cognitive domains that interferes with one's normal activities. And again, there's a spectrum from mild to moderate to severe dementia. I'm going to spend a little time first describing what happens in dementia and then describing what happens in HAND. And then we can talk about the similarities and differences. When I say dementia, it really is an umbrella term. It represents impairments in cognitive function that really lead to significant hampering of one's normal activities. And in that umbrella, we have Alzheimer's disease, which is by far the most common of the dementias, Lewy body dementia, vascular dementia, frontotemporal dementia, and other forms of dementia, which are much rarer. Now, at the very bottom here, I'm pointing out that mixed dementia is surprisingly common. In fact, perhaps the most common thing we see when we look at autopsy of someone who's had dementia is not one pathology, but more than one pathology. Several times, 3 or even 4 different pathologies. In Alzheimer's disease, the brain degenerates over time. And what you're seeing in this cartoon is a slice through a normal brain on the left and an Alzheimer's brain with advanced pathology on the right. And the MRI images that are in the background give you the views of these slices through the brain. I want to point out several things. Is that in the brain, of course, we have the cerebral cortex shown here with this pinkish ribbon throughout the brain. We have these deeper subcortical structures, such as the basal ganglia. And then we have the hippocampus here, which is critically important for memory. The cortical ribbon is markedly thinned in Alzheimer's, leading to shrinkage of the brain with these more generous fluid-filled spaces, including the ventricle here. And the hippocampus, this critical organ for memory, is also markedly impaired. I want to point out that in Alzheimer's disease, these subcortical structures, the basal ganglia, which are so important for movement, for example, are typically not affected. And that's a point of distinction. In HAND, in persons living with HIV, the subcortical structures and the basal ganglia can be affected, leading to things such as movement disorder. Now, in Alzheimer's disease, there is this amyloid cascade. We know that amyloid deposition occurs early in Alzheimer's disease, and what you're seeing here is an image of Alzheimer's plaques in the brain visualized using PET ligand imaging. The A beta or amyloid deposition probably leads to some inflammatory events that involve microglia. And we're going to come back to that point because we also see that in HIV disease. And this then precipitates, through mechanisms we don't fully understand, the accumulation of tau protein in these neurofibrillary tangles, leading to dysfunction and neurodegeneration. Now, what I'm showing you here are PET ligand imaging of an Alzheimer's brain, showing the tau accumulation that occurs in the brain and showing the amyloid accumulation. So these would be the tangles, the neurofibrillary tangles, and these would be the plaques. And what I want to point out is that the actual sites of deposition of tau or tangles versus amyloid differ quite a bit. An important point about Alzheimer's is they're very characteristic regional depositions of these two signature pathological hallmarks. And we don't see precisely this in hand or HIV-related disease. This is an extremely simplistic schematic of the factors that go into leading to Alzheimer's disease. They include genetics, the apolipoprotein E isoforms, lifestyle decisions, how well educated one is, whether one has a challenging job, whether one smokes or not, whether one drinks or not, chronic illness, hypertension, hyperlipidemia, diabetes. These are all factors that can contribute to a cognitive impairment and eventually dementia, and a process of inflammation. All of this occurring as we age, leading to many people developing mild cognitive impairment or MCI, and many of these individuals then go on to dementia over time. Now remember this slide because we'll come back to a similar slide in HAND or hand. Now let's focus on hand for a second. Again, as I emphasized, this represents a spectrum of neurocognitive impairment. Things that we notice are changes in cognition, impairments in attention or cognitive processing speed, working memory, and executive functioning, or decision-making and the ability to multitask. In addition, people with hand can have numerous behavioral changes, including depression, anxiety, sleep problems, apathy. And there can also be motor disturbances, an unsteady gait, poor balance, loss of coordination, tremor. I want to emphasize that whereas in Alzheimer's related pathology and MCI that goes into Alzheimer's, we typically don't see problems with motor function. In hand, we see it quite often. And in addition, I want to point out that this efficiency in learning and retrieval are reduced, but primary memory disturbances are relatively rare in hand, whereas in Alzheimer's, primary memory disturbances are almost pathognomonic. In hand, that is not the case. Now, we've got to remember that there are many potential neurological manifestations of HIV disease, and these can be associated with hand. And so I, as a neurologist, when I see someone in the clinic who has known HIV disease and is being treated with antiretroviral therapy, and they have balance problems or motor problems and new cognitive problems, I'm not going to assume that it's hand. I'm going to be looking for other causes as well. And what's pointed out here is that HIV can involve the central nervous system or the peripheral nervous system and many different sites of attack. I might, for example, be concerned about a myelopathy and do spinal cord imaging if I see hyperreflexia in my patients. If I see weakness, I might be looking for a neuropathy or muscle disease. But let's focus here on the cognitive components in hand and HIV-related disease. I think it's important to recognize that roughly half of individuals who are living with HIV are neurocognitively normal. They have no complaints of cognitive problems, and we don't see cognitive problems on advanced testing. There are also about a third of individuals who have what's called asymptomatic neurocognitive impairment. They don't have any behavioral issues. They do have some mild cognitive deficits, but it does not interfere with their normal daily functioning. When it does begin to interfere with normal daily functioning, then this would be called mild neurocognitive disorder. And when it's marked impairment with daily functioning and marked impairment in multiple cognitive domains that we can test, then that would be HIV-associated dementia. Let me point out that this is pretty rare. In the era of antiretroviral therapies, thankfully, HIV dementia is quite rare and has gone down quite a bit over the last 2 decades. Remember that slide from Alzheimer's disease of the schematic of things that contribute to Alzheimer's? Very similar in the case of hand. Genetics and lifestyle make a difference. Even the apolipoprotein E isoforms that we see that are relevant to Alzheimer's can be relevant in hand. Obviously, shared chronic illness, in this case, persistent inflammation. Remember that HIV as a virus gets into our non-neuronal cells, gets into the brain through microglia, and can be there persistently, even with effective ART therapy. And I want to point out that while, of course, CART is critically important in reducing the burden of HIV disease, there can be effects from the medications themselves that could be contributors to hand. And again, all of this now is occurring in the context of age. I want to emphasize that both hand and AD are age-associated conditions. In fact, more than 50% of persons living with HIV in our country today are over 50 years of age. That is emphasized in this graphic, where individuals 50 and older who have HIV disease are really making up the bulk of cases. So it's important to think about age-associated cognitive decline in HIV. Advanced age is an important predictor of susceptibility to developing hand in those who have HIV. And in fact, people with HIV who are in their 50s and 60s, in part because of HIV presence, appear to function cognitively more like persons in their 70s and 80s. Probably there are 2 separate things going on. There's chronic HIV disease, even when there's suppression of the virus due to effective therapy. And there's also the changes that occur with the biology of aging in the brain, and they're independently going on, but they may also be synergistic. And I will add as well that there can be superimposed on this intrinsic neurodegenerative disease processes such as Alzheimer's or Lewy body disease. In persons living with HIV, the rate of MCI is higher than those who don't have HIV. Here we're looking at all individuals over age 50, and you can see here that the rate of HIV MCI is much higher versus those who don't have HIV. And if we parse that out into those individuals who are 50 to 60 or over 60, you can see that individuals with HIV presence have a much higher rate of MCI. And part of this is because people who have HIV are more prone to have comorbid illnesses, particularly major comorbid illnesses. As highlighted here, in individuals over 65 who have HIV, almost 75% have 2 or more major comorbid illnesses. This can be diabetes, hypertension, hyperlipidemia, cardiac disease, all of which are also modifying factors that can contribute to the likelihood of developing dementia over time. Well, you might ask yourself, why would we even want to distinguish asymptomatic neurocognitive impairment from MCI? What's the point of this? I think it really comes down to effective care and treatment for our patients. MCI has a well-established natural history and associated behavioral and clinical management algorithms in individuals who don't have HIV that can help us understand what might happen in someone who has MCI. Also, MCI is associated with a high risk of progression to actual dementia within 5 years, whereas ANI is less clearly associated with progressive cognitive decline. So distinguishing the diagnosis here can have real prognostic and treatment implications. I will say, however, that the clinical relevance of ANI in persons living with HIV is sometimes unclear, and it actually may overlap with MCI. And I think here's a case where the principle of parsimony probably doesn't apply. I think with the aging brain, very often more than one thing is going on. So people who have chronic HIV disease, even if it's well treated with antiviral therapy, may have a second illness going on. It could be an intrinsic neurodegenerative process. They may have multiple addition additional comorbid illnesses that are contributing to changes to the brain. I do think also that by identifying ANI versus MCI, there may be interventions that we can think about that we would give in some individuals and not in others. Here's a very important point. In this study, it was shown that obviously individuals who have normal cognitive function and who have HIV don't show changes over time in terms of becoming symptomatically impaired cognitively. Individuals who have asymptomatic neurocognitive impairment over time, some of them do, less than 50% do show some progression so that they actually become symptomatic. But again, half of them really don't progress over time. If I were to superimpose, and this is my drawing on this particular graph, what it would be like for amnestic MCI that would go on to Alzheimer's, you see a steeper and more continued progression to dementia over time. So this is an important distinction to make. And again, a progression of hand over a 4-year period in those who are on effective therapy, it usually does not progress. 30% of those with ANI show progression to mild neurocognitive disorder. More than half remain stable, and some actually get better over time as we identify potential causes of their cognitive impairment. Mild neurocognitive disorder does not progress to dementia in about 70% of persons. And I think it's important to recognize that the consequence of long-term chronic HIV infection, where nervous system damage was actually triggered prior to the initiation of antiretroviral therapy, may not be fully reversible. So many people who have very mild, and I guess you could say even asymptomatic neurocognitive difficulties will remain the same over a long period of time, and it could be residue from their early HIV infection. So what do specific cognitive symptoms suggest when we see them? If they're stable over time, and in someone with HIV, it's probably hand. If they have inattention, slowed thinking, poor decision-making without decline, but not major memory issues, it's probably hand. On the other hand, if there is clear progression over time, you got to be thinking about something else going on, including a primary dementia. If they have significant memory complaints and difficulties with recognition, again, I'm thinking something other than hand. Here is that point made again with a few more features. Again, if it's stable over time with some inattention, slowed thinking, poor decision-making, probably hand. If, however, there is a significant memory and language deficit and recognition is impaired, I'm thinking that this is likely amnestic MCI and will likely progress to become dementia over time. You might ask, are there biomarkers for hand? Could we do some simple blood test or some other test that would tell us that it's hand versus AD? No. There are no clear diagnostic biomarkers. The diagnosis is really one of exclusion. We rule out confounding conditions. Obviously, in someone who has HIV disease, we want to be thinking about opportunistic infections, things like neurosyphilis, substance abuse, toxic metabolic disorders, psychiatric diseases, depression can occur in those with or without HIV. And finally, age-related dementias. It's important to recognize that asymptomatic neurocognitive impairment typically occurs in people who are well treated with antiviral therapies, and they have suppressed viral loads, they have good CD4 counts, and they don't usually have significant markers of immune activation. Because now many more physicians and healthcare professionals are aware of hand, I think it's identified earlier and more frequently, and I think that's why it's important for you as healthcare professionals to be thinking about distinguishing it from a progressive degenerative process. Imaging is important, and I, as a neurologist, get imaging on all the patients, almost all the patients that I see who have cognitive impairment. And traditional brain MRI, for example, or even head CT can be used to exclude structural inflammatory processes, but it really doesn't allow us to say, indeed, it's hand versus dementia. A hand brain will appear normal until late if it's progressive, and atrophy can be noted. There are often white matter changes. They are often in the periventricular regions, but this is true also in many of the intrinsic dementias. Brain mapping studies suggest that, unlike in AD, hand atrophy patterns can include the basal ganglia, the caudate, the putamen, and some other subcortical regions, so that can be a clue. I want to remind you that amyloid can accumulate in hand, and it's probably somewhat linked to the pathology of HIV disease. So a positive amyloid PET scan does not prove that it's Alzheimer's. That can be seen in hand and doesn't indicate that indeed is clearly Alzheimer's as the underlying basis. I think it's very important to recognize that hand probably shares some pathogenic features with AD. There is amyloid beta perturbations and accumulation that occurs in hand in an HIV disease. We don't fully understand it, but it's almost certainly tied in some ways to microglial activation and involvement in HIV disease. By the way, microglia are critically important in Alzheimer's too, so I think there's a shared link here. One thing that's very important is that while there can be amyloid accumulation in hand, there's not a clear link to tau deposition. Whereas in Alzheimer's, absolutely, there is a temporal correlation between amyloid deposition and tau deposition, and tau really is the critical marker of neurodegeneration. We don't see that in hand in the same way. Finally, will say that genetic risk factors such as ApoE4 alleles, which are a risk factor for dementia, can certainly amplify and moderate the neuropathology leading to hand. I think we have blood biomarkers that are going to be available very soon in an Alzheimer's disease that we might apply to distinguishing between hand and MCI dementia. For example, a plasma marker, phospho-tau 217, is highly sensitive and specific for AD. There are many studies out there that describe this, but this is one from JAMA in 2020. It involved a Swedish study as well as parallel studies in UCSF and WashU. Also was seen in individuals who have familial Alzheimer's disease. You can actually detect changes in tau even up to maybe 20 years before symptoms. And I think it won't be long before these kinds of blood tests are commercially available, certainly for amyloid and tau, and they will be clues to whether there is Alzheimer's or something else going on. At this point, we still need evaluation of these peripheral blood biomarkers in real-world settings to see how clinically applicable it will be to the HIV population. But I do think that we will use this in a subset of persons living with HIV to distinguish hand from MCI dementia. Is HIV like Alzheimer's a neurodegenerative disease? I think the answer is yes and no. There are clear differences. HIV is unquestionably a viral disease that affects the nervous system, both peripheral and central. And we don't think that AD is a intrinsically viral disease. And I put that we think there because there are plenty of good scientists who think that viral exposures can change the sort of immune and inflammatory state of the brain in ways that could lead to amyloid accumulation. Pervasive and severe memory deficits are a typical hallmark of AD, and that's due to a degenerative process, but not in HIV disease. Eventually, there's severe dementia with a localized, that is, regional amyloid and tau pathology in Alzheimer's, but we don't see clear tau accumulation and neurodegeneration tied to tau accumulation in HIV disease. I think the cognitive and neuroimaging data in Alzheimer's point to an early and prominent hippocampal involvement, whereas HIV usually shows a more frontal and subcortical pattern that could be more of an inflammatory than a degenerative process. But again, I've hammered this point that they share some pathway elements. And I think, although I put it in parentheses here, that there might be immunological or inflammatory connections that lead to a common therapeutic target down the road. Now, when I see someone who has HIV, I don't assume that it's hand. I don't assume that it could be a dementia. I look for other things. Of course, alcohol and drug-induced cognitive disorders are not uncommon in people with or without HIV. Depression, anxiety, and other mental health problems clearly can be contributors to cognitive impairment. Vascular cognitive impairment caused by small vessel disease, whether or not it's tied to diabetes or hypertension, is very common both in HIV and without HIV. And stroke, whether it's a small mini stroke or whether it's a larger scale stroke or multiple strokes, can be contributors to cognitive impairment. So of course, these are things I'm looking for when I am distinguishing someone with HIV, whether they have hand or dementia or something else going on. In summary, persons living with HIV have increased risk for MCI and dementia, and it manifests at a younger age than those who are negative for HIV. The advent of antiretroviral therapy has lessened the severity of HAND, but not the frequency. Thankfully, we have much less HIV-associated dementia than we used to have. The pathogenesis of HAND is complicated and multifactorial and does share some features with AD, including an important intersection with brain aging. And I'll mention again microglia as a common connection between the two. The cognitive patterns of declines in executive function, attention, working memory, and learning efficiency differ in HAND from Alzheimer's and fits more of a subcortical pattern. HAND is much more likely to have other neurologic symptoms and signs, including motor impairment and involvement of the basal ganglia. And when cognitive symptoms are progressive and HIV treatment parameters confirm that there's effective therapy, I think it's important to consider a superimposed Alzheimer's or related dementia process or some other process as well. I want to end by thanking the Michigan Department of Health and Human Services for providing the Alzheimer's Association and our center, the Michigan Alzheimer's Disease Research Center, with a grant to put together educational materials on HIV, including this lecture. And if you want more information, there are plenty of links, both at NIH and the Alzheimer's Association, the Center for Disease Control, and several papers that can be helpful to you as well. Thank you very much.